like to thank the organizers for inviting me. It's a pleasure to be here. This talk is going to be on bispecific antibodies in cancer therapy. Let me just advance. So these are my conflicts of interests as part of this program. So the field of immuno-oncology has revolutionized the way we manage our patients. I'm a thoracic medical oncologist, and under that category, obviously, immunotherapy has had a significant impact on how we care for our patients. However, not everybody benefits from these drugs, and unfortunately, there is always disease progression, and therefore we believe that alternative approaches can be quite useful in the management of some of our patients. Now, these alternative treatments are sometimes combinations with different checkpoint inhibitors, and sometimes are newer molecules that are entering the clinical practice. And talking about bispecific antibodies, of course, that's what we want to concentrate on. Bispecific antibodies are not new to cancer therapy. As you can see, you can go back several decades with the introduction of one of the first antibodies, actually. And I was lucky enough to work with a person who was my mentor in the lab, where he actually made one of the first bispecific antibodies to enter clinical practice. Of course, it was not successful, unfortunately, but nonetheless, the field has come a long way, as you see on this timeline of drug development and technology development. There were a lot of issues with the bispecific antibodies, obviously antigen targeting, the structure of the antibodies, how you choose things, and then we've come to a point where we now have these bispecific T-cell engagers or BiTE molecules that I'm going to cover briefly that really do seem to offer additional advantages. We have bispecific antibody drug conjugates, so the chemistry and the technology has improved quite significantly. So what is a bispecific? Well, it's a typical antibody that can target two separate antigens. These antigens can be two separate antigens on the surface of a cancer cell. In the case of a BiTE molecule, again, as I will show you, it can be one tumor antigen and a T-cell antigen, in this case CD3. But the idea is that the bridging of two different tumor antigens can actually bring the immune system in more closer proximity to the actual tumor. And also, it increases the specificity of the antibody because now you're targeting two separate tumor antigens. And if that's successful, then you have a variety of options, as you can see on the particular slide, where you can actually attach I have to learn how to work with this pointer. You can have an ADC made of it, so you add a toxin that enters the cell. You can have an effector cell engaged. And again, the idea here is that the two targets increase the specificity of the antibody. On the bottom, on the left-hand side, there are the different structures that we initially started with, but a more complicated version of it, a more sophisticated, I should say, is shown on the right-hand side. And the idea here is that we now have the technology to make these antibodies in a variety of formats. The flexibility of antigen targeting, the linker that's used, if you add a toxin to it, the kind of toxins that we use, all of these have improved tremendously, allowing us a lot more flexibility in designing drugs. So do they work in the clinical practice? So what are the evidence? And again, I'm going to concentrate on solid tumors. One of the first bispecific antibodies that has been approved for use in thoracic oncology right now is this compound called amivantamab. As you can see on the slide, this is an antibody that targets both an EGFR and MET. And why is that? Well, the target was selected because in the world of lung cancer in patients with EGFR mutation positive tumors, after exposure to a TKI, MET is amplified quite substantially in the number of our patients, and it is a resistant mechanism. Therefore, it was thought that if you can have a drug that targets both, maybe you can overcome that resistant mechanism. So this is a fully human bispecific antibody, IgG backbone, targets both the EGFR and MET. And the idea here is that, again, with this, you can have better clinical efficacy in patients with various tumors. Now, Exon 20 insertion is a particular issue in the world of lung cancer because it is usually a mutation that does not respond to standard TKI. So the way we develop drugs, of course, is that we go after a refractory disease or more difficult disease to treat. And here, this particular antibody was specifically tested in patients with exon 20 insertion, again, because we really don't have a treatment option for this patient population. Checkpoint inhibitors by themselves are not thought to be active in these molecularly driven tumors because we believe that the tumor microenvironment is rather cold, so the use of checkpoint inhibitors by themselves has not been that effective. Combination with chemotherapy is thought not to be effective either in this particular group, so again, an area of need. Chrysalis is the name of the study where this particular compound was actually tested. So as you can see, this drug underwent a typical dose escalation followed by a dose expansion clinical development. For the dose expansion, the phase 2, you'll see that there are 2 separate doses based on the patient's weight. And the primary endpoint, like it is for the majority of phase 2 studies that we do nowadays, just response rate. So about 81 patients with exon 20 insertion, non-small cell lung cancer were enrolled. As you see on this table, patients were heavily pretreated prior to entry, which again is pretty standard for these phase 1-2 drugs. And you see that overall a response rate of 40% was achieved with a single drug. Now, the number 40% might not sound a lot, but for those of you who take care of a lot of patients with lung cancer, particularly the molecularly driven tumors, that's a very impressive number, particularly because the patient population that was investigated here had undergone a number of prior therapies, including prior checkpoint inhibitors. The forest plot is basically a subgroup analysis, and the numbers here are a little bit too small to really draw significant conclusions. But the waterfall plot, I think, is pretty indicative of the clinical activity. So again, a 40% response rate, and you see that the responses were seen regardless of where the actual insertion is. So again, for those of you who are in this field, you realize that exon 20 insertions and EGFR can have mutations at every component, every part of the gene. And there are some drugs that seem to be better active if it's targeted to the far loop versus near loop. This drug seems to be active regardless of where the mutations are. And again, keep in mind that some of the patients here had a ctDNA analysis to pick up the exon 20 insertions, again, suggesting that in addition to the drug activity, we're able to detect these mutations by a number of different methods. So it seems to be an active drug. So what is the problem with it? Well, this table summarizes some of the side effects that have been seen as part of the study. The biggest issue here, as you see on the bottom of the table there, is that this drug can actually cause infusion reactions. The infusion reactions are common, and it is something that you need to pay attention to. Obviously, an IV administered, so the nursing staff and the infusion room staff have to be trained to actually look for this. Most of the infusion reactions are of grades 1 and 2. They're not significant. Nonetheless, majority of patients have suffered from them. Therefore, it is important to sort of keep that in mind. The rest of the side effect profile are very similar to what we get with other EGFR-targeted therapy. And what I mean by that is rash, GI disturbances, nail changes, very common. And there are a few MET-specific alterations also, such as peripheral edema, which is a sort of a class effect that we see with most of the compounds that are targeting MET. Based on this study, US FDA has approved amivantamab for patients with exon 20 insertions for use in the US. These are obviously, again, patients who have undergone some form of initial treatment and have evidence of disease progression and now are capable to get this drug. Further development of this drug now was also just presented at this year's ASCO. Here, the idea is to combine this drug with a specific EGFR TKI that targets the more common EGFR mutations. This is called lazertinib. It's a third-generation oral TKI. It's thought to be similar to osimertinib or Tagrisso that we use now, but obviously it has to go through their clinical development. And the concept here is that combined use of a EGFR TKI like lazertinib plus a bispecific antibody like amivantamab that targets both EGFR and MET could potentially overcome any future resistant mechanisms that might be coming, especially if it's thought to be through the action of MET being amplified. It is also thought that the use of this particular antibody can alter the tumor microenvironment so that the immune effect of it can be more exploited. Now, everything that we use nowadays is thought to induce some immune responses. I'm sure you've seen it. To what degree that really is true for a lot of the compounds that we're talking about is really not known. But I think it's also pretty clear that in these molecularly driven tumors, any manipulation of the target could potentially change the tumor microenvironment, and therefore it is not unreasonable to think that you can have an immune effect here. And this is basically some of the rationalization as to why it is that we think this particular combination can be effective. Again, starting with targeted therapy like osimertinib, eventually patients have evidence of progression, and these bypass mechanisms have been worked out for the majority of them. And again, we think that having the ability to intervene a little bit sooner might actually delay this resistant mechanism. So this is a phase 1 design of the study that's still ongoing. Some of the data that was presented concentrated on only 45 patients, so very preliminary data. You see that these patients have all had either first or second generation or third generation EGFR TKIs. And the spider plot here does indicate pretty deep responses in some of these patients. So the overall response rate at this point is 36%. Again, this is a patient population where if it was standard of care, really platinum doublet chemotherapy would have been our next option with a response rate of around 30%. Again, we don't think immunotherapy alone or in combination is going to be all that effective here. And you see that in patients that actually had resistant mechanisms that was more EGFR or MET was MET-based did have responses. So this one is 47% if they have an EGFR MET. This is the MET patient population. Again, you see that on the MET there are a number of different fusions that can be targeted. So it does appear that both patient populations benefit from this drug, but one in particular, MET alteration, seemed to be a little bit more. Moreover, there's a simple IHC that's being developed for this. And why is that important? Well, again, having a biomarker that's easy to use and cheap and effective in selecting patients, I think matters. So more data to come on for the development of this drug. And again, the genetic information matches the IHC data. So this drug is active. We have access to it in the US in the refractory patient population, and obviously a lot more for the drug development. So, one bispecific antibody that seems to work. What about these BiTEs? So these are bispecific T-cell engagers. Here, you have a lot more of the immune system being active in it. It's a little bit simpler than CAR T approaches because you don't have to take the T cells out, manipulate them, put them back in a patient, and you are directly engaging the T cell. So this is a schematic on the right, on the top part. That's the normal immune system recognition. You have MHC involved, you have T cell receptor involved. And you see on the bottom that if you use a BiTE, you actually can have a mechanism that's independent of engaging the T cell receptor MHC, such that, again, you have your tumor antigen targeting moiety of the BiTE. You have the CD3 targeting moiety coming together in a smaller structure. It's not as big as an IgG. There are two single chains coming together. Therefore, you bring in the T cell in close proximity to the tumor because you have the tumor antigen engaged, you have the T cell engaged, so they shouldn't meet in the middle. And the result is the release of cytokines and chemokines that causes cancer cell death. So these are some of the specifics of a BiTE, which makes it a little bit more interesting. The first version of these BiTEs were difficult to use because they have such a short half-life that they actually required daily continuous infusion, or a couple of examples of them in a hematologic malignancy. But we now have these half-life extended molecules. So you get the BiTE, you add a little Fc domain to it, and it allows it to stay in circulation a little bit longer. So now we could potentially give this drug once every 2 weeks kind of a thing, as opposed to a continuous daily infusion. Clinical data, again, there are a couple. The blinatumomab is in the world of heme malignancy, targets CD19 and CD3, has been quite effective, has undergone a number of clinical developments, and this drug, again, is already FDA approved in the case of ALL. And again, this is older data, so I'm not going to spend a lot of time talking about this, but quite active in the world of hematologic malignancies. And again, as I said, this is an agent that's been tested in a number of different phase 3 studies. In pediatrics, in patients with adult ALL, in patients with minimal residual disease. And the adverse events compared to standard chemo or transplantation seems to be a lot more manageable. Obviously, you are engaging the T cells, so there are cytokine release issues that you have to deal with, but nonetheless, for a patient population that used to not have a lot of treatment options, this compound seems to be quite active and tolerable. In the world of solid tumors, one of the clear examples that we have of a BiTE molecule is this Amgen 757 drug, also called tarlatamab. This is a half-life extended BiTE molecule that targets both DLL3, which is an antigen commonly expressed on the surface of small cell lung cancer, and that's what we're targeting here. And it engages the T cell. Again, you see the schematic of how a BiTE might actually work. This can lead to T cell activation, which then can cause serial lysis of tumor cells. Now, why concentrate on small cell? Another major area of need. We really don't have a lot of good options for patients with small cell. The standard of care at the time of initial diagnosis for metastatic disease is a platinum doublet plus a checkpoint inhibitor with an overall survival of about 12 months median. So unfortunately, and a much shorter PFS. So an area of need, and DLL3 is highly expressed, so it made sense to target this. We participated at FoxChase in this study. 66 patients were enrolled up to, or evaluable, I should say. A lot more patients have been enrolled, and more data is going to come. You see that majority of these patients had good performance status, but almost everybody had prior treatment as it's required for most phase 1 drugs. Of the 66 patients that enrolled, 44% had a cytokine storm or cytokine release syndrome, which again is something that if you work with a T cell engager or any T cell directing drug, you're going to have to deal with that. Unfortunately, there was one death due to pneumonitis, but since then we've been able to manage the side effect profiles. What about the activity? So, so far on the 66 evaluable patients, we have a response rate of roughly 20%. And again, the comparator here would have been, in this case, topotecan in the US, which is a very harsh drug with a lot of myelosuppression and a response rate around 10% with a PFS that's in a matter of a couple of months. So the responses were seen across many different dose levels, as you see on the waterfall plot. The recommended phase 2 dose is still being worked out, and we think we're almost there, and we're hoping that we have additional data for this patient, for this particular drug. Another anti-DLL BiTE3 drug that's still in development is this compound from Boehringer Ingelheim, and this is actually an ongoing study also, so we don't have a lot of data for it, but the concept is very similar. So you have a tumor antigen coming in close proximity to the T cell directly. These are some of the other potential targets for a BiTE molecule. Many of these are already in clinical practice. The PSMA for prostate cancer has been quite successful, and I'm sure in subsequent international meetings you're going to hear a lot more about targeting PSMA, not only just in prostate cancer, it's also relevant in lung and a couple of other malignancies. So these bispecific antibodies and BiTEs are progressing through clinical development quite rapidly. I'd like to highlight two special areas of concern. One is cytokine release, which is the systemic inflammatory response as a result of a direct T cell activation. It can impact the cardiovascular, respiratory, neurologic, renal systems. And neurologically, again, if you're familiar with the CARD literature, patients can have seizures, coma, a whole bunch of other issues that can happen with them from a cardiovascular point of view. Hypotension and other issues are very common. It requires immediate recognition, IV fluids, high-dose steroids, and in cases cases that are refractory to tocilizumab, anti-IL-6 antibody, is commonly used to overcome these. Neurotoxicity is real. We've seen a couple of these at our center. It can range from simple headaches all the way to seizure and coma. And unfortunately, some of these can be fatal. Now, using bites, I have to say, it has not been quite as bad as CAR T-cell specifically. Nonetheless, it is something that requires very frequent neuro check for patients who are being treated on these phase 1-2 studies. So that is something that we're ongoing. Potential resistant mechanisms, it makes sense if you're targeting a tumor antigen, loss or downregulation of tumor antigen, T-cell exhaustion is a problem, and other escape mechanisms, such as overexpression of PD-L1, for instance, can be another potential mechanism where these drugs can lose their activity. So I'm excited about these compounds. Obviously, we work with them. We like them. I think tumor antigen selection is very, very important here. I think CD3 engagement is a tested and, as far as I can tell, somewhat proven strategy for overcoming this immune inactivation. And obviously, resistant mechanism, something we're working on next in terms of combinatorial studies. I'd like to thank you for your attention, and I'm happy to answer any questions.